Okay, thank you all for coming. Welcome to the first event of the semester of the Philosophy and Medicine Colloquium. I'm Sherry Rausch. I'm a professor in the philosophy department, and we have a website, which you might know, philosophyandmedicine.org, and all these other things. And can you click to the next slide? Yeah. The other thing is we're sending around a sign-up sheet. If you want to be on our mailing list, we'll send reminders of events. And then I think we'll get right to it. If you could shut off your any devices that make beeping sounds, that would be great because we're recording. Yeah.
Yeah.
Mm-hmm. So we'll get right to it. Our speaker tonight, Brendan Clarke, is a philosopher at UCL, and he's going to talk about causes and correlations and how to tell the difference between them. And I'll just let him begin to speak.
Okay. Thanks very much. Can you all hear me? Yeah, brilliant. I hope my voice lasts the evening. It's been a difficult week for the colds and flu, I'm afraid. Thank you very much for the introduction. As Sherry said, I'm a lecturer in history and philosophy of medicine at UCL, which is actually where I clinically trained in a fairly common kind of career path for people who end up doing philosophy of medicine. But today we're going to talk a bit about evidence, and particularly the kind of evidence that you might like if you're trying to make good medical decisions. So without sort of too much mucking about, let's start thinking really about ways of generating evidence. This is, in a very schematic way, what most people think of as the standard way of generating evidence that guides therapeutic decisions in medicine, the randomized control trial. Put very simply, the idea is that you take some population of people that you want to test a drug on, you randomize them into several groups, and then you apply different interventions to those groups. You follow them up, looking particularly for the kind of outcomes that you're interested in, and then almost always do some kind of statistical analysis, and it's that statistical analysis that feeds in as the evidence that you use to make clinical decisions. What I'm going to be talking about mainly today is something a bit different. It's the idea of using mechanisms, and particularly evidence of mechanisms, to do things in medicine. I'm going to presume that terminology is a bit less familiar to you than the kind of RCT thing, which I think is fairly standard. So a very brief introduction, in fact, on one slide. A mechanism for a phenomena consists of entities and activities organised in such a way that they're responsible for the phenomena. What does this mean? Well, this is a way of thinking about things that do causal stuff, right? If we're interested in how and I will try out my pointer for the first time, A causes C, what we do if we're working in this way is to figure out if there's a mechanism that connects A and C. It's very straightforward, I think. We're also going to think about evidence of mechanism, which is, again, I think, fairly straightforward. This is any evidence that you have that such an ABC type mechanism might actually exist. I hope that's not too kind of complicated. So evidence that this process, this ABC type process, is in fact there. So the project that I'm currently involved in fact, will be involved on for about the next 3 years, is about using this kind of evidence of mechanism to make better quality medical decisions, and particularly to use it in concert, in combination with the kind of things that you get out of drug trials, which are, as we kind of mentioned, roughly evidence of correlations. We've got various goals, and today I'm going to talk really quite specifically about one of them, which is the question of how you say something sensible about the quality of that mechanistic evidence. The reasons for this, I suppose, are as follows, that I'm going to leave this slide to sink in for a second, because I know this is the kind of thing that lots of people have up in their flats for one reason or another. I find this very stressful. This is the kind of thing I think that most people think of when you say mechanism. which is some horrendously complicated kind of attempt to be very comprehensive about the detailed workings of one biological process or another. Right in the middle there, I think, is the Krebs cycle. Right. So this is the kind of thing that I think people think of when you say mechanism, and it's kind of a worry because it's incredibly complicated, incredibly hard to work with something that's that busy, that has that many thousand things involved in it, that all of those processes going on in some very chaotic way. What's more, when we look at things like drug trials, we actually have this very apparent simplicity, right? Let me put up one slide, which is supposed to be the most important thing that appears in the whole of the grade guidelines. For those of you that haven't run into these things before, the grade guidelines are one of the methods, probably the most widely used method in the UK, for ranking different kinds of evidence from clinical trials. Okay, and here you've got this very, very straightforward, what is it, about 8 category ranking of evidence from clinical trials that goes from 1 with 2 stars to 4, from best to worst. Very much more, well, this is, I think, is a really successful simplification of the way that you might grade, and I suppose that's where the name comes from, right? That you might grade clinical evidence that arises from trials. So, what's the point of trying to do something much more complicated? This is the usual question that people ask us more or less politely when we go and talk about this project. We've already got nice, simple ways of evaluating evidence. And the answer, well, I hope the answer in some detail will become apparent to you over the next half an hour or so. But the usual way that we answer it is to try and think a bit about what we might do with evidence, which is usually to make better clinical decisions. Let's think about a dead simple clinical decision, what you might call a sort of A-B decision. Given the choice between 2 very similar treatments, how do you decide which one to give? How do you decide to give medicine A or medicine B? Well, the usual simple answer is that you look for relevant clinical trials. And what you'd ideally like to find, right, is some nice clinical trial that directly compares A and B in some relevant population. Does that make sense? Nice examples of this kind of thing, well, I think that the example that we're usually thinking of here is something like the kind of ways that you prescribe for high blood pressure. High blood pressure is a very common clinical problem. It's probably the most common reason for getting a prescription in the UK. And there are a very large number of drugs available that purport to treat, that say they treat high blood pressure, right? How do you decide which one to give? Well, you look to the clinical trials. That's the answer. And actually, we've got some help here because there are very many clinical trials of blood pressure drugs. And so NICE, National Institute for Clinical and Health Excellence, is that what they are this week? They keep changing their name, but not their acronym, which is confusing. But NICE have a nice clinical guideline, which synthesises some of this very complicated biomedical research. And actually, we can look at NICE Clinical Guideline 127, and we can find out that if we're treating somebody under 55 years, we can offer them first-line antihypertensive therapy, which is an ACE inhibitor, and that, from clinical trials, is supposed to be straightforwardly the right answer. Okay, so we can also, if we're feeling particularly keen and enthusiastic, look to the full guideline. We can actually look in a very direct way and find out what bits of clinical research ground this kind of claim, right? And in fact, I'm not sure how well that's playing at the back. I will try and make these slides available to you afterwards if you're interested. But there are a very large number of little superscript numbers up here, and each one is referring to a trial or a publication on a drug trial, right? So that claim that these particular group of antihypertensive medicines is best comes from, well, I suppose actually a relatively small pool of clinical research studies. So, well, in some ways, that seems to be that, right? We know that this works better in trials. So, that's right, isn't it? Well, we think there are reasons to be a bit suspicious, a bit more careful, maybe, about the way that we try and ground these clinical decisions. And to start explaining why that is, what I want to do is think a little bit more carefully about how clinical decisions actually get made. And the first thing to note, I suppose, is that even when we're making fairly simple clinical decisions, these kind of A, B prescription decisions, there are actually a very large number of factors that kind of participate in this decision. Right? We can think about the benefits of the drugs, like we just did with the ACE inhibitor example. We can also think about the harms that the drug might cause. And those two things might well be different, actually. Even just those two factors to think about might give us a rather complicated decision. For example, a drug that seems to be very good at reducing blood pressure but seems to have lots of side effects versus a drug that isn't so good but is much safer. That's not a very straightforward thing to kind of reason out. We also will want to think about the reference class, and I'm going to assume that that's a term that most of you have never heard before, so I'm going to explain it in a couple of slides' time. It will have to wait for a surprise until then. We need to think about some other stuff as well, like price and the kind of outcomes that we want from the treatment, right? Is there any point in giving somebody medicine to treat their high blood pressure if they're already dying of 6 or 7 other things at the same time, right? That might well change your kind of decision. And then I've rather patronisingly lumped together lots of patient factors, and particularly things like consent as being another kind of facet of this rather complicated decision. Now, I suppose the first kind of point is that we need to know at least a little bit about each of these in order to make a prescription decision. I think there are probably a few other things as well, but I don't want to go on too long. But the thing that really interests me is that actually the structure of this decision is very complicated, right? So non-consent, if a patient refuses to take a medication, will trump everything else. No matter how good the medicine is, if somebody doesn't want to take it and are competent to make that decision, they don't get it. They won't be forced to take it. On the other hand, positive consent, saying that somebody wants to take a drug, doesn't trump in the same way. It doesn't beat everything else. You can consent all you like, but if a treatment is, say, too expensive to use or doesn't show the right kind of profile of benefits and harms, then that decision won't go that way either. So actually, I think the structure of this process is rather interestingly complicated. So, well, what does this have to do with making decisions about drug trials, and what does this have to do with mechanisms? Well, let's take a step back and think about why the usual answer is look at a trial. There are many kind of... A final point is that these bits of the kind of clinical decision-making process are distributed between actors, and apologies for the social science terminology, but the kind of the majority of the weight of that decision rests on different people, depending on who you're looking at, right? So if we're looking for benefits, we particularly find that some of the public bodies, like the Cochrane Collaboration or NICE or so on, will actually do most of the work in making that decision. They'll publish, in fact, simple clinical guidelines that clinicians can go and look at. On the other hand, other bits of this are firmly kind of left to the clinician, particularly things like consent. We don't get any help from policy bodies about consent issues in an individual case, almost always. So, back to the point then, what does this have to do with anything really? I wanted to kind of point back at one of the most widely cited papers on evidence-based medicine. I'm sure for those of you that are in the medical programme somewhere, you will be about to encounter this thing. 11,683 citations as of this afternoon, which is more than any other paper I know, I think. Evidence-based medicine is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. Similarly, from later in the paper, there are other claims here about how you're meant to practice medicine in an evidence-based way. Now, I don't want to get into a kind of social history of evidence-based medicine. That's not what we're here for. But what I want to try and do really is note here that if we take these kind of slogans or quotes seriously, it's very clear that evidence that comes from clinical trials is part of the clinical decision-making process, obviously. But it isn't constitutive of it. It doesn't just make it. There's more to clinical decision-making than clinical evidence. So back to the context of our clinical decision-making. So we're beginning to build this kind of, still fairly schematic kind of model of how these decisions come about. And we typically have some of the big kind of health bodies who produce evidence about benefits, harms, and about pricing. And then we have this sort of clinician side, what might happen at the bedside or in the GP surgery or something, where a clinician will kind of use that evidence and negotiate in some way with the patient to make a clinical decision. The reason, I think the most interesting reason to be nervous about straightforwardly accepting this kind of model of clinical decision making is it leaves out one of the factors. It leaves out, in fact, a very important factor on this list. In fact, I think probably the most important of all. And it's the one that fewest people know about, I think, certainly on the clinical side. This is about reference classes, and that's what we're going to talk about now. So, a nice example. What is the probability of my house burning down next year? Does anyone want to have a go? A guess? Roughly? Well, all right, how do you go away and find out? How can you make an evidence-based prediction? Any ideas? Well, I mean, I suppose the usual answer might be to go and look at some statistics. We could go and find out what the probability is of houses in London burning down, which is actually surprisingly high. Don't go and look these statistics up, they will worry you. So we can go away and look at the probability for London as a whole, and assuming, you know, my house is in London, so I will assume that the probability of my house burning down is basically the same as that sort of overall probability for houses burning down. It turns out, though, that we can also get nice statistics for South London. Now, this might be better, being in South London. These might be better, right? Maybe they describe the properties that my house has relative to burning down more closely than, you know, the London statistics, which also include all of that North London business that I don't know anything about, right? The worry is, though, and in fact, this is an empirical worry, this really happens, the rate of house fires in South London is slightly higher than in London as a whole. So I've got two different probabilities. Which one do I pick? Any ideas? It depends what we're using. It depends what we're after. We can keep going. We can keep looking at different levels of statistics. And actually, it turns out that in this example, they are all different. They all give different probability estimates for my house burning down. Okay, apart from the blue front doors, no statistics available on that. But I want to bet it's different from any of the other ones too. On and on it goes. Now, here's the problem. So my house is a member of all of those groups, right? It is in London, it is in South London, it is in Tooting, it does have a blue front door and so on. But all of these groups have different probability estimates. So which one should we pick? Well, that, in a nutshell, is the reference class problem. Which one do you pick? And actually, it seems to be one of these very unusual and interesting problems in philosophy that is both very well characterised and yet seems to have perilously few solutions other than use your judgment, use your best guess. Now, as we'll see, this applies in a very, very tricky way to what's going on in these kind of clinical decision-making. Before I do that, though, let me just note that actually there's some kind of similar instances here in this nice clinical guideline that we've already talked about high blood pressure, where people from different ethnic groups and of different ages are offered different medicines to treat their high blood pressure. This might be an example of a very similar style of reasoning to the kind of thing that we've talked about just then with reference classes. Let's go back and think then about our clinical trial and try and relate it to this reference class problem. This is my very, very schematic outline of what happens in clinical studies and the way that those clinical studies get applied to populations, right? So we take some study population, we randomise them, we do our clinical trial, we think very carefully, we evade sources of bias and all the usual things that we should do if we're good biomedical researchers, right? And we eventually come up with some kind of statistical result that nicely describes what actually goes on in this study population. We then, in a separate context, take that trial result and apply it to some treatment population. Now we can think about these two kind of branches with some rather neat terminology, which is the idea of internal and external validity. Very briefly, internally valid studies are one where the trial result is a good indicator of what occurs in this study population. Okay? On the other hand, external validity are cases where the trial result applies very well to the treatment population. So if we know that a particular drug makes you live 5 years longer in a study, if in an actual population it also seems to make people live 5 years longer, we'd be singing and dancing very happy about the external validity. Now here's the worry. What if there's kind of reference class difficulties that apply to this? What, for instance, if our study population have no comorbidities, that is, other illnesses, and our treatment population have very many? And actually that's the kind of thing that you would typically expect in things like clinical trials of blood pressure medication. It's well worth looking up the kind of details of these. These are tested in populations of people who look very, very unlike the treatment population. Typically young, typically, apart from the high blood pressure, very healthy. There's a worry then here about external validity that we're missing because both of these have high blood pressure, right? It's just that they seem to be different in this reference classy way. And what's worse is that it's very hard to do anything about this. It's very, very hard to take a trial result that is developed on one population and apply it to another. Extremely hard, in fact. And it means that we should be very cautious in predicting outcomes when that kind of thing happens. But here's the third part of the problem, which is that for reasons that have to do with internal validity, there's an enormous pressure on trialists to make their trials on populations that do not look like treatment populations. The reasons for this are a bit complicated, but essentially it's to do with ensuring that you get really clean and tidy results out of your clinical trial. Do it in populations of people who aren't otherwise ill. And that's a problem for us, and that's one of the reasons that we're trying to think a bit differently, I suppose, about clinical decision making. Just as a very brief aside, I want to kind of point to this, which is from one of my favourite history of philosophy books, David Albright's The Arch of Knowledge. He talks about a device that kind of runs through the history of philosophy about epistemology, right? The idea that there are very many different ways that people have said this same general idea, which is that we go out into the world, we observe things, and then we apply some general reasoning and produce a result that is sort of fully general, right? Like a law of nature. Applies to anything, lasts forever, valid everywhere. And that we go out and we apply this sort of law of nature type knowledge to the world, and we can do so very reliably. It's a very interesting book. And it seems a very interesting kind of way of thinking about how this kind of clinical trial work might be happening, right? The idea is, I suppose, that we're trying to produce a canonical result, a result that tells everyone in any circumstance whether drug A is better than drug B. Actually, I think there are reasons to be very nervous about that, extremely nervous about that. as we've already mentioned, the reasons for this happening have to do with the kind of demands of designing studies that can produce nice, clean results. That, after all, is the thing that gets you published, right? Nice, clean, tidy results with narrow error bars and all the rest. But that comes at this cost of minimising the kind of, if you like, the applicability, the external validity of study results. I think there's a less obvious worry here too, which has to do with the way that the people who founded EBM, evidence-based medicine, in the 90s, portrayed this question about extrapolating, about applying general trial results to individual people. So, that, I suppose, is the problem. Well, what to do about it? I suppose... Oh, excuse me. Well, there are lots of things to do about it, and lots of suggestions and lots of interest in doing clinical trials a bit differently, or at least adding in something a bit different to make trial results a bit more useful. One very major group of solutions that I've been interested in but won't talk about anymore today is the idea of using real populations for clinical research. Collect data from GPs and see what actually happens when you treat real people with drugs, right? Nice idea that gets around some of these difficulties. But what I'm going to talk about today is a slightly different approach, which is to think differently about the way that we put evidence into our clinical decision-making process. And actually, in a nutshell, what I want to suggest is that I think we can use these kinds of causal mechanisms to help us make assumptions about how to apply clinical evidence. Okay? Just a reminder, we're talking about mechanisms as some organised, structured arrangement of causally interacting parts or things. And we're talking about evidence of that mechanism, so evidence that is the kind of process that's underlying what we see. Let me think about a toy example as to how this, to sort of introduce the idea of how this might work. Say we have some correlation, the kind of thing that we might produce from a trial. Some intervention, some drug is correlated with some effect, some side effect, maybe. A nice example would be, in the blood pressure example that we're thinking about, would be the ACE inhibitor type drugs and persistent cough, which is a well-known side effect of some of the ACE inhibitors. Right? We can attach, if you like, a mechanism that might underwrite or explain that correlation. That's not a controversial thing to say, I think. And actually, people who know more about respiratory physiology than me have a pretty good idea what this mechanism is. Now, the problem is, as we've already touched on, there's so much mechanism to pick from, right? We know an awful lot about biology. We know a lot about drug action. And it's very, very complicated to try and reason out why particular drugs might have effects. They're complicated. One of the suggestions that we've had is that there might be some ways of breaking down that complexity into something that's a bit more simple, a bit more like the kind of ways of thinking about clinical trials and evidence of correlations. And to do that, actually, we've been using a legal analogy. Abrupt left turn. So, there's this strange thing about lawyers, that they think about tons of different kinds of evidence, right? Actually, when you start reading legal cases, which I have no legal training at all, it's worth pointing out and sort of apologising for, and I'm sorry to any of you that do, for any errors that I make. But lawyers deal with this enormous and bewildering profusion of different kinds of evidence, right? They have all this expertise in dealing with different kinds of testimony, for example. Testimony from people who might, for one reason or another, want to lie, or might want to tell the truth, or might want to emphasise things, or might have been out of their brains on something. All kinds of different testimonies, and they seem to have ways of working with it. They also get, particularly in the kind of criminal cases, have this enormous set of impossible to understand material stuff. It seems that nearly anything you can think of has been evidence in a courtroom at one point or another. And I mean, kind of on and on it goes. More or less anything can get used as lawyers' evidence. Bewildering complexity. How do they deal with the complexity? Well, and how do they select what evidence is really important? How do they select the relevant stuff? You see the analogy, right? And how do they evaluate it? How does this one lawyer know all about cocaine and know all about, I don't know, maps of South America and know all about ballistics results and all the rest of it? How do they gain this expertise? Well, the answer is they don't. Of course they don't. They couldn't possibly. And in fact, they have this rather nice way of describing the kind of work they actually do with evidence, which is that it's substance blind. I love this. You just ignore it. You ignore all the details. And essentially what you do is you construct ways of working with evidence that allow you to borrow the expertise of others in some very structured way to make decisions with evidence. This is from a very nice book, Anderson, Schumann, Twining, 2005, which is a very nice introduction to the way that lawyers work with evidence. Well, I suppose the question is then what does it look like? If you ignore all the actual detailed kind of technical scientific properties of the evidence, what does it look like? Well, actually it looks weirdly simple. You start drawing little graphs. These are called Wigmore charts. I'm going to presume that you haven't seen them before, and I'm going to do sort of 3 minutes of basic explanation on what these are. So the first thing to note is that they're inference networks, right? They set out, if you like, a way of thinking about a particular legal verdict. Makes sense? And they're read from the bottom to the top. Roughly at this bottom layer you have your evidence. You then have some process of kind of reasoning with all these different kinds of evidence and sticking them together and so on, and eventually establishing a legal verdict. That's the plan, right? What's very interesting is that if you look at the notes that lawyers take when they're preparing court cases, you'll find that in any given case, lawyers on different sides will construct different Wigmore charts using the same evidence. Now, this really is interesting, right? This is fallible. It doesn't guarantee that you get the right verdict, right? You can, like all of us, whenever we reason or argue or anything, you can be wrong. It's not a tool for generating truth out of untruth or something. It's instead a way of very carefully representing the way that people think about evidence. And very roughly what happens is that you have these kind of nodes that are particular bits of evidence, and then you can think of these edges more or less as probability modifiers. So if you have these kind of lines going up into a node, it raises the probability that that will be right. And one of the great advantages here is that you can scale these up. So you can put hundreds and hundreds and hundreds of pieces of evidence in, and people do. They draw these things that are the size of a lecture theatre, more or less. And they show the structure of the evidence. They show how dependent and independent parts of the argument might work. It's also, interestingly, for legal purposes and possibly for medicine, it's atomic, so you can actually sort of break an entire argument. You can break an entire sort of conclusion by one node going wrong. It's not a sort of weight of evidence kind of thing. Does that make sense? Anyway, so these are one of the tools that we're thinking about as a way of working with evidence of mechanisms in medicine. There's a little bit of detail here that it might just be worth talking very quickly about, which is to point out that this isn't a straightforward kind of a straightforward lift. We can't just steal this and use it in medicine. There's some translation to do. The biggest part, I suppose, is that, and this is a legal example again, that you're typically trying to prove this thing, what they call the ultimate probandum, which is typically the form something like X murdered Y, right? That would be in a court case. You're the prosecution. You're trying to prove that someone murdered someone else, and that's your sort of conclusion. And in law, the first, or the sort of top part of these charts is extremely clearly defined, okay? So actually you usually have this more, a legal definition of what counts as a particular offence. So I don't actually know in detail what it will be for murder, but something like means and motive and opportunity or something. That seems very unlike the medical case. And you establish the individual kind of parts of the penultimate proband of these kind of given by definition parts of the conclusion by generalizations, and these are typically pretty safe and pretty uninteresting, right? So if you're trying to show that X murdered Y, and you're trying to show here that X had the means to murder Y, and your evidence is something like X was seen leaving Y's house after the murder, your generalizations are going to be something like you have to be near someone to murder them. You get seen coming out of houses. I mean, terribly sort of straightforward generalizations, right? Nothing very complicated at all. Let me try and wrap up then by linking this back to clinical decision making in the last 5 minutes. So these kind of inference networks, I think, are plausibly compatible with thinking about health, thinking about clinical decision making. For one, they're fallible. We're not trying to introduce a machine for getting the right answer. These are instead tools to support clinical decision making. We have this nice idea that we're dealing in a system that is probabilistic. That's quite useful when thinking about health things for a great many reasons, really. One great advantage is that we can very easily represent the kind of complex relation between different parts of clinical decision making. Like the example with consent that we talked about at the beginning. Negative consent trumps everything, positive consent does not. So we can very easily represent complex dependencies using these. And for reasons that I don't want to talk about too much, really, it's also a way of thinking atomically about evidence. You can treat separate bits of clinical evidence separately and use them in a way where they're independent from one another to make clinical decisions. It's useful for the kind of complex systems that we're typically working in when we're making health decisions. One final assertion, then, is that I think they're going to be particularly useful for telling you how you can pick bits out of your mechanistic knowledge about how disease works. And I mean, this is not terribly controversial either, I think. But the idea is that I think we can draw some nice connections between causal mechanisms, A causing B causing C, and the kind of inference steps that we might draw about those causal mechanisms. This is not meant to be very, very complicated at all. But we can easily think, if we have this sort of three-part causal mechanism, that we can easily construct some kind of network of inferential steps too. And that seems quite an interesting way of using these kind of Wigmore charts, inference networks, to do some of the work of selecting relevant and important parts of medical mechanisms. And particularly because it might mean that you could find out what bits of mechanisms you could safely leave out and what not. Does that mean that we can do it? Well, it's kind of an open question. I mean, this is work in progress. This has been going on for 3 months, and there's roughly 3 years left to go. So I suppose I'll come back and tell you in a while. But, I mean, the kind of conclusions, such as they are at this very early stage, is this is in a tradition of doing philosophical work that's meant to make something that's probably already happening, at least in some way, more explicit. That actually being explicit about your methods and your tools is an important kind of step in improving things. There is, as I've already mentioned, various things that need to be done to improve this, and that's kind of current work that we're on at the moment. And particularly this issue that we've already mentioned, that you have sort of defined legal verdicts, right? We know what murder is, but actually we don't in the same way have sort of stipulative definitions of clinical decisions in that way. A third point that I enjoy is that what we're trying to do here is do something that's very close to the original kind of setup of EBM. Their argument was not that doctors were making decisions completely without evidence in the long, long ago, before there was such a thing as evidence-based medicine, but that they weren't being explicit about it. There was no really direct link between the evidence and the decision. Instead of looking at trials, as we've looked at, you would go and ask your boss or a senior colleague, or do what you did last time, or something like that. So actually, I mean, the point is here that we're trying to be explicit about a slightly different aspect of evidence work in medicine. One of the things that interests us is that actually you could seem to stick lots of different kinds of evidence in these charts without causing too many problems, right? On purpose. They don't take any notice. It doesn't matter what specifically is in them. So, I mean, the final point really is that they seem actually to be very flexible. We can do lots of different things. We can support lots of different kinds of clinical decision making in broadly the same format, and that seems useful too. But given that I'm 2 minutes or so over time, I think I won't go on about that for too long. I should very briefly thank, first of all, the Arts and Humanities Research Council for their support for this work. I also want to plug our project website, EBM Plus, where we've got some other strands of this work just coming online now. Thank you all very much indeed. Oh, I should hand over. Sorry.
Thank you, Brendan. I just want to introduce our commenter, Nikki Cohen, who's a pathologist at here, GKT School of Medical Education. And
thank you. So when I'm not doing medical education, I'm a brain pathologist, a brain histopathologist. So I'm a qualified medic who wanted to spend a bit more time asking why, I guess, which is how pathology happened. And for me, it's always been about the brain. So that's how neuropathology happened. And I can promise there was actually very little collusion here, but we end up using many of the words in slightly different ways. So for me, evidence-based medicine is about understanding populations. But to my mind, to treat a patient, you've got to understand that patient. You've got to understand the biology that underpins them. You've got to understand it from a cell and a tissue and a mechanism way. So for me, the mechanism is how did that do that to that organ, to that person? How can I alleviate that? And I think we run the risk globally at the moment of concentrating so much on population-based science that we lose out on understanding biology. And if we don't understand biology, we won't develop new drugs, let alone know how to treat them. And I think we have to go back to cells and tissues and organs to understand. And I'll show you what I mean. There are some pictures, they are moderately gruesome, but not all of them. So this is a post-mortem that I did about 2 years ago. I don't do silent witness. I don't do forensic cases so much. I do coroner's cases and things like that. So the gentleman behind this brain was a highly regarded, upstanding member of society. And for reasons that I won't go into now, one morning he went to a park bench and he shot himself. And I could look at his brain, and in reality, I didn't need to be much of a doctor to be able to do this. I could look at his brain. Where's your pointy thing gone, Brendan? Can I borrow your pointy thing? Yeah. And I could see a bullet track, right? This guy died because he shot himself through the brain. That's the mechanism. Do I need to understand the tissue here? Probably not so much. There's lots of interesting stuff going on in the tissue, but it's secondary to the point of how he died. He died because a bullet went through his brain. End of. In terms of understanding the tissue, so here is a slice through somebody's heart. The left ventricle is at the top, the right ventricle is at the bottom. Move over this way. Ah, okay. And I can look at this tissue and look at areas of white and understand that this chap has areas of fibrosis in his heart because he's previously had episodes of myocardial infarction. But now I'm being told where to move, and now I'm in front of my slide. Okay. So this is a chap who's previously had heart attacks, and he's had some remodelling that's gone on because you can see the thickness of this ventricle is quite thin because he's got heart failure. So I can infer the biology behind it by looking at the tissue. And I can go one step further. Anyone know how he died? I know I've got some medics in the room. Well, when I was dissecting him and I came to dissect his heart, what I saw was a pericardium that was full of blood. And it was full of blood because he's had an acute myocardial infarction and he'd ruptured his left ventricle. So I can look at the tissue and understand the mechanism. But I could go a step further. Okay, so I've shown you some gruesome, so I had to go back and show you something cuddly. Now, I showed my son, who's 10, this slide a few months ago, and he went, "Mum, why are you showing a picture of a bear?" I went, "Oh, good point, I hadn't seen it that way." And there's another picture of a bear. Can you guess what the next slide is? You've got to have 3 of them. There you go. 3 bears. Now, the top picture on the left-hand side is stained with an antibody that labels cells that are dividing. The one underneath it labels cells with an antibody to a type of lymphocyte, type of white blood cell. And the little one labels to another type of lymphocyte. And this is really important because by looking at the cells, I can tell you what's wrong with this patient. This patient didn't die. This patient had treatment as a result of understanding the cells and understanding the biology and the mechanism. So, this chap had a lymphoma. He's got lots of cells that are proliferating. And the cells here are B cells. And he's got a type of lymphoma that is a B-cell lymphoma, which is a very common form. And we know through looking at tissue like this in cancers such as this and translating this work that we can develop antibodies to this protein. And if we turn that into a drug, we can treat a whole load of inflammatory kind of conditions. So, rituximab, which is a drug that many of you will know, it's a monoclonal antibody, is one of the primary agents involved in antibody therapy, and it treats lymphoma, it treats multiple sclerosis, it treats rheumatoid arthritis. They can all be considered to be inflammatory disorders. And the benefit of understanding the biology and looking at the tissue and understanding the cells is that I know how to treat it. So yes, you can do that and use that to apply it to a population, but if you lose that, you don't know where you're going. And that's it. Thank you.
Okay, thanks to both of you. I want to open it up to questions, unless Brendan has something to say to that, or want to just open it up to questions?
Yeah, well, questions first.
Questions.
Anybody? Yeah.
No, sorry. I'm
No.
okay, sorry.
Okay. No reason to be shy. Yeah.
But mechanism, I mean, is that intended to be restricted to kind of biological mechanism in terms of their medicine, or is that?
Well, can you hear me? Yeah. No, almost certainly not. It's one of these strange things about talking very early on in a project that it gets very hard to pick all the different strands apart. So actually, one of the other things that we're working on is about what kinds of mechanisms you're likely to need to invoke. And actually, some of the most interesting information, some of the most kind of interesting conversations that we're having are people who are working in public health and on social determinants of disease. About the kinds of mechanisms that they are typically engaging with in their work, right? So quite often these mechanisms are not just, it's not that you have to attach everything straightforwardly to biochemistry. It's
There's other stuff.
there is other stuff apart from biochemistry. Yeah, exactly right. Does that make sense?
kind of confused. So we set up, here's a reference class problem,
Yeah.
right? Maybe something like mechanism is going to help us out here.
Yeah.
And then we did the jump to the Wigmore chance, right? So, it's in a way that you set it up as like, here's a way which lawyers can make decisions about cases and how these different bits of evidence are connected inferentially. And that seemed to be more analogical to how do we treat a particular patient in a particular case, rather than helping us understand how mechanisms help the reference.
Okay.
So I just saw those things as disjoint and maybe can help them together.
Do you mind if I put some slides back up? Is that okay? So yeah, you caught me. You caught me on a bit that I was that was in the talk and then went out of the talk and then back in the talk for a while. So one of the points is then that we have this reference class problem. We have this nasty kind of difficulty in describing, or rather in picking, in some objective and principled way, which, my God, it's a long way back. It's in some objective and principled way which sort of class we use, right? Now, actually, if you treat this as a problem about sort of hidden assumptions, right, it actually becomes much less difficult, right? There is no particular problem in saying, well, for various reasons, I'm going to use South London. Okay, it's just a very non-objective kind of answer. Worse, if you do that kind of thing and then present a straightforward probability value, you turn a conditional probability into an unconditional one in a rather naughty way, because you're giving a probability estimate that's based on my house conditioned on being in South London, but presenting it as some sort of objective unconditional probability. So I think that using particular mechanisms to actually try and figure out, to try and help with some of these difficulties around the reference class is quite a good solution. Particularly when they're attached to this very explicit way of talking about the inference, because then you can say what your kind of your reference class type assumptions are. And I think that doesn't need to necessarily be restricted to individuals, although the work relating individuals to groups is fantastically important. But I think it might also apply when you're doing population to population inference too. The kind of examples like most of our drugs getting tested in populations that are in principle unlike the ones that use them, for instance, would be a very good example of trying to use mechanisms to correct, or rather to select particular reference classes and adjust them as required.
So that's not a biological mechanism in that case, right? You're saying.
Well, it might be, mightn't it? I mean, so for the one that we're worrying about now is that we know that lots of antihypertensives work differently in people with broken kidneys, right? And people with chronic kidney disease are usually excluded from hypertension trials. So one of the things that you might like to do would be to look at the kind of mechanism by which the drug works.
Why mechanism?
Well,
Why mechanism?
just so.
Yeah.
And then I mean, this is precisely the point about trying to decide which bits of mechanism you're going to use, right? And that's how this helps.
Great.
Does that okay?
Can you just illustrate it with this example of the fire? What mechanism would you appeal to decide? What would it look like to appeal to a mechanism to decide which reference class?
Oh, right, all right.
I'm just
This is actually quite a hard one because I don't really know anything about house fires. So the mechanism that I was really interested in is it turns out houses in South London and North London are different. And the houses in South London are better at catching fire because they're built more cheaply. They're also just better, you know. There's actually a very large number of houses which are built using pine construction. So they have lots of very resinous pine in their roofs and under their floor joists and all sorts of things. This is magnificently flammable. Nice mechanistic story, right? So you can actually start talking about, when you're talking about my house, there might be an in principle reason to, or rather there might be a decent reason to prefer the South London reference class because my house is one of the ones that apparently burns down fantastically easily. And I really wish I hadn't learned this kind of thing. Yeah, and it's not just the sort of, I mean, the answer that very often comes up from people who like this kind of mechanistic way of thinking is you just sort of think about the mechanism in some general way. But actually, I mean, I think thinking about the inference network is a way of trying to specify what kinds of mechanisms that you might like to look at. So here, mechanisms that talk about causes of fire would be extremely good things to look at. I suppose you could also have kind of social thing as well. Maybe people smoke more in bed in South London. Don't know.
There are plenty of examples where you have an understanding of a mechanism that leads you to a treatment, and yet the treatment doesn't work.
Yeah.
And for example, people say oxidative stress damages,
Therefore
so we'll
vitamins.
give antioxidants.
Yeah.
And what happens? Actually, it aggravates the situation. So having a mechanism
On its own.
Yeah. So to what extent do you have to, I mean, talking about the relationship between what you've been talking about and what you started at the outset with randomised controlled trials, to what extent do you have to validate through a more general approach afterwards?
I think it has to be both, really. You've got to integrate them. Yes, you can't use mechanisms on their own to make clinical decisions.
It's all very well understanding one bit of your really complicated diagram.
Yeah.
But unless you understand the rest of it.
Yeah. So actually, I mean, we've been the way that we started thinking about this was the idea of something like reinforced concrete, where you mix two kinds of different things that have different material properties that mutually support one another, right? So the idea is that doing trials is great, except they can be confounded. They can be confounded very easily, and it's very hard to deal with that kind of problem. Mechanisms too are very good, but for example, you can just get mechanisms totally wrong. You can tell true mechanisms that don't make a difference, like the oxidative stress and vitamin intake kind of story.
Well, they make it worse, actually. It's not just that they don't make a difference, they can actually aggravate.
But it wasn't that there was a mistake about the mechanism that they thought caused the effect. It's just that didn't really contribute at all, right? So the point is to try and integrate the two, because they actually in some way seem to be kind of mutually supporting. That's the plan. So no, yes, this is not an appeal to just making very large and complicated medical decisions because you know a good story about how something works. Absolutely not.
And it may be to an extent that not only do they complement each other, but if you look at their weaknesses, to see how their weaknesses interact, because on the one hand you've got the weakness of mechanism where you may have some other part of the mechanism you don't know about.
Yeah.
And then you've also talked about the weaknesses of RCTs.
Yeah, so that's, I mean, we're typically thinking about stuff like masking, where you get multiple mechanisms that connect some A and some B, and it's not very clear which one does most of the work most of the time, or does most of the work under particular conditions, or whatever you like. So yeah, actually, I mean, I think there's something quite useful there about looking for kind of evidence of correlations as a way of solving that kind of murky problem. There is a much more kind of mathematised, Bayesian network-friendly way of thinking about this as well that's being done down at the University of Kent at the moment, which hopefully, I mean, beyond me, but yeah, hopefully is going to be able to describe some of that stuff in a very formal way.
Yeah.
Can I ask this? I mean, is this intended as almost an empowerment of clinicians in the sense that this is how clinicians should be approaching evidence-based, and therefore almost an individual responsibility for the clinician to construct these in their decision-making, or is it intended as a how does NICE therefore make policy for us?
Yeah.
Where is it aimed at?
So the project we've started, and we're working basically with people who make evidence at the moment. So we are working with NICE, and we're working with, for one reason or another, loads of people in Holland, and in the sort of in the health policy and the government health and social care department. We're also working with IARC, who are, you probably might not be that familiar to you. So they're a branch of the World Health Organization, and they deal with environmental cancer risks. one of the things that's interesting us is that they were already using kind of evidence about mechanisms in their guidelines in a very anti-EBM, or no, sorry, not in an anti-EBM way, but in a different way from most of the people who were making guidelines in the 2000s. So we're initially working with those people, but we're also looking to work with practitioners as well, because I think potentially there are some ways that this kind of, I mean, okay, for most straightforward care decisions, this is too much. This is too much. Do I give you an aspirin? Yes. It's just unnecessary. But I think it is the kind of thing that could give rise potentially to tools that are going to be helpful to the clinician in making very complicated prescription decisions. I'm not sure if I answered your question, I'm afraid.
Well, I think in a way it can sort of be empowering for clinicians in the sense of, I think the danger with guidelines is that it stops the thinking and people don't really understand it. The probability does not mean that this patient will therefore respond because there's trial. I think in a way, if it helps actually evidence to be translated into practice in a way that's actually thoughtful, it would be a good thing. That actually clinicians actually can use evidence and a paper as part of the decision-making network. Actually, it's probably a good thing.
Yeah, I hope so. But I mean, everyone like me who ends up in doing sort of evidence enthusiast type work causes clinicians more work and causes things to be more complicated, at least if they're successful. And I'm not sure that's necessarily a good thing. So I'm yeah.
Yeah, I was going to ask about the probability in your models.
Yeah.
I mean, certainly, you talked about these Wigmore charts and the importance of these probabilities feeding into the actual outcome that you get at the end, whether the guy is a murderer or not. But I mean, many of the decisions that you talked about in clinical medicine didn't have a probability. They were, an all or nothing. The patient gives consent or they don't give consent. How do you factor those things into your thinking? I mean, do you have to have a probability?
Well, I mean, so yes, actually, the consent one is a rather unusual part of this decision because it is so straightforwardly black or white. Let me try and answer in a couple of different bits then. So when you look at what lawyers are doing with the Wigmore charts, they have this very strange idea that the connections are a probability raise, but it's sort of an unspecified probability raise. It just makes more likely. And I've never seen one actually that's been worked out with actual probability figures on it in any way. I don't know why that is. Maybe it doesn't make any sense to do it. Maybe I don't know. I honestly don't know. For us, though, we think there's definitely a way in which you can work in a closely related way that is really almost exclusively about probability and the manipulation of probability.
So
right.
The probability is probably a murder.
Do what?
Is that what
Well, again, sorry, I don't really know about the kind of legal case here because
Reasonable doubt.
beyond reasonable doubt. But what is that? What number is that? What's reasonable?
95%.
Is it 95%?
Actually, some jurisdictions, they give that instruction. Some they don't.
Do they really?
But jurors say that they have an easier time if you give them a number.
How do they know?
95%.
So, I mean, that's an interesting question to see if there have been kind of quantitative formulations of these. There are a very large number of these out there, and they're not that easy to get hold of. So there could well be a side to this that I've missed. I mean, I think the kind of decisions, particularly that clinicians will be reaching, will be very, very probabilistic looking, right? One thing that I'm wary about is just saying, well, because we can interpret this in a probabilistic way, that's sort of what clinicians are already doing. That seems a kind of basic mistake about psychology, confusing your conceptual scheme with sort of empirical psychology or something. So I don't know, but I mean, it's an important part of the work we're doing, and it seems very plausible that these can be interpreted in a probabilistic way or attached to some kind of formal causal model of some kind.
But mean, the case of the legal case shows that you wouldn't need to be putting specific numbers on it in order to do something.
Don't need to.
And in fact, if an expert in my field got up and said that there's a 1 in 20 chance here, that this is something wrong, case dismissed.
Yeah.
That would be a reason to.
Yeah.
Yeah, please.
Yeah, you talked about consent, which is an absolute thing. But there's another aspect here, which presumably lawyers don't have in their Wigmore charts, which is what's at the heart of patient-centred care and the patient's desires or expectations. Yeah. And how does that come into this? Because after all, I mean, consent is a rather absolute thing in the sense of I won't have that treatment, but there's more to it than that, isn't there? And that doesn't come into your Wigmore chart. I mean, obviously the accused wants to be found not guilty.
Yeah, I mean, but I see no reason that you couldn't incorporate that kind, because there's a decision-making process there too about needs, right, and wants. I mean, do you think, or is this something ineffable that we can't sort of describe?
Well, I don't know. I don't know whether you model it. How it comes in, how you incorporate it, whether you have two separate parts to this, or whether you have it. That's what I'm asking.
I think at this,
how do you deal with that?
Well, at this very preliminary stage, the idea really is to regard all of these points as being separate kind of branches in one chart. So actually, because I mean, this is one of the great advantages that this is substance blind. You can put in whatever you like into that kind of inference chart, and it doesn't cause you any sort of logical kind of problem or anything like that. I see no reason that you couldn't invoke wants and preferences here. And we see that kind of happening in clinical decision-making where sort of non-consent preferences sway prescription decisions. So I know that, for example, things like different kinds of painkillers, GPs would typically listen to patient preference, right? Yeah, of course. Of course, even if that might not be the kind of optimal solution in terms of price, benefits, harms, and all the kind of more...
But often patient preferences will be contradictory. You know, I want to be cured of this cancer, but I don't want to suffer nausea.
Yeah.
I mean, you know, so how do you deal with that? Because then it becomes much more complicated.
But this is kind of what these charts are for. They're for dealing with contradictory evidence. You know,
Isn't that the art? Isn't that the art of what medicine is? I want that, but I don't want to get this. Isn't the way that the patient is taken through that by somebody who can understand it, can articulate, be empathic, can do all of those things?
Yeah.
Isn't that about the art of medicine and the art of being a practitioner? And if you break it down to... Sorry, but if you break that
if
down
you break
to
it all down into...
you lose something.
Well, you might well. I mean, this is not meant to replace the clinical encounter. But I think as a tool for thinking about these kind of complicated decisions that actually seem to... I mean, one of the parts of work that we're going to go and do is actually try and talk to people making decisions a bit about how they do it. And these decisions that I think are made in a very... Well, because I've done it, I mean, in a very sort of seat-of-the-pants way, that would be the kind of description, right? That you're not sitting there and writing, well, this one is the more expensive and this one is the safer. Gut. Maybe. I try and avoid saying that particular word because things are going badly for me. This is not meant to replace the clinical encounter, but for times when, for occasions when things are difficult and where decisions are very complicated and where, like as I think happens very often, demands are competing all over the map. This might be a very useful tool in sort of decision support, I suppose.
Just a comment about that. It seems like if you're talking about using the Wigmore charts for decision making, it's missing, what I heard, it's missing something because that chart is probabilities of propositions. It's not preferences. It's all about how do I figure out what to believe. Whereas the decision making also
that's
involves
interesting.
desires and preferences. So there are systems where you can put those together and layer them and stuff, but I don't see it in the Wigmore chart.
That's very interesting. I will get into that. Yeah.
Yeah.
I just wanted to highlight to the last exchange. So I can see scenarios in which patients might be very comforted to have a model of decision making that they can look to see what sort of evidence is being considered. Because one thing that struck me about the Wigmore charts might be that I guess there is a worry with, I guess if the lawyer seeks something like a binary end product like guilty or not guilty, and outcomes of patients might vary huge amounts under what they can expect.
Yeah.
I guess I thought it would just be that it's not obvious to me that there aren't certain types of patients for whom gut or art would be much more frightening than detailed inference patterns.
Yeah. I think that's a very transferable difficulty, isn't it? That the information and quantities of information and kinds of information need to be tailored in some way. Yeah, I would hate to think of the idea of waving sheaves and sheaves of these things at people when they're sick.
And maybe the Wigmore thing is about innocent proven guilty. Well, how are you going to knock that down? And in reality, you're probably going to knock that down with association and with numbers that may not add up to anything. But you're going to try and pretend that you've quantified it in order to see. Maybe that's how that comes about.
What's that? So you end up pretending.
But if the basis of the Wigmore is that the line is a probability that doesn't have a number behind it, then you're just trying to tick the innocent or proven guilty.
Yeah. I see in its original. Yeah. I mean.
Is that how that's grown? I don't know.
So I don't know. It's very hard to comment on the kind of history here because they seem to spring more or less fully formed from Wigmore. There isn't an enormous story about how these kind of come to be and are kind of refined. I mean, I take the worry about the kind of probabilities. I think this is one reason to think separately about explicitly kind of quantitative techniques really for working with this kind of stuff. And the interest here is something that's relatively informal. Not meant to provide all the possible detailing.
It seems like presumption of innocence is in there in a neat way. If you think about that chart as bricks and gravity, prosecutors trying to build a case. If one of the bricks comes out, it falls down. So it's like gravity is enforcing innocence until
there are lots. I mean, the funny thing is that if you look at competing charts from the different legal teams, they are actually structurally typically very similar, which I find remarkably interesting. And it's more that, say, you would emphasise one piece of negative evidence over a piece of more apparently positive evidence in relation to some verdict. It's actually fairly. The changes seem fairly subtle, right? There's more. 90% of these charts are shared between the two, and it comes down to fairly kind of subtle stuff. And that, I think, in itself is probably quite an interesting thing to think about in this context,
They
right?
have to be shared, don't they? You can't go to court with a piece of evidence that you haven't shared.
Yes, but it still surprises me because the generalisations are so. They just seem so sort of vacuum. I mean, most of the links are so sort of
common sense.
Like common sense. You'd think that they would be so easy to permute, or just to come up with some kind of different way of relating it. There's something about legal training, I think, that's quite important in these.
Doesn't that raise the question, though? I mean, in the law, like you were saying, some of the things are really clearly set out. Like, what's really required to prove for murder means murder opportunity. There's another feature of it that's sort of given, that is not given in the medical case, which is the default is that what that ground thing is innocence. What's the default in the medical decision case?
Yeah.
Are we assuming by default that the treatment won't work, or are we assuming by default?
Yeah, and you end up in a different position again when you're thinking about A/B decisions, or when you're thinking even about treatments.
Is A on the bottom and B has to be
Well,
shown,
that's
that's
the kind of work that we're just kind of getting going on now.
So you've asked two already.
I know.
Like it.
I mean, it's a very interesting approach to the issue of external validity, which I've never really touched on. I mean, we've done a lot internal validity and trying to prove the outcome of trials, but actually external validity and your approach in terms of a deductive approach is interesting in starting off with mechanism. I'm just wondering, actually, could you, I mean, I don't know if my thinking is wrong here, but you know, could you start by going backwards? So start with your population that you want to apply it with, and start with the evidence that you have beforehand, and then apply various mechanisms to see if you actually get back.
Yeah.
Is there that approach that you could take?
Well, that's exactly what's going on at the moment, where observational trials in real British populations are happening by GP registers and other things like that. I don't know about going backwards, but that's sort of the idea is that you can do these kind of observational studies and then use existing clinical studies to kind of correct some of the very well-known problems with doing purely observational research and that kind of complicated observational research.
So those real-world trials, you're saying, is actually that approach?
Yeah. Or at least you're more sort of meeting in the middle, if that makes sense. You're invoking real populations and their outcomes as being something that you feed into your decision-making process.
And you hope to get mechanisms out of that?
No, I've got no idea. So that's an approach that I'm just really not talking about here. Actually, I mean, I think it's probably something that's terribly important, but it's not. I'm not trying to address that at the moment. I don't see why. In fact, I think that doesn't give you mechanisms at all. I think that gives you a set of very, very hard to interpret correlations that probably make a lot of sense when they are interpreted along with the kind of, if you like, the more clean, pure stuff that comes out of drug trials and some mechanistic thinking and some ideas about how your populations work. But that it doesn't give you mechanism, no.
Yeah.
If you use outputs from randomised controlled trials in the way that's fairly standard now, decision-making processes, they still can be quite complex and it still takes quite a while to get all the factors out. If you say, well, actually we're going to have a freer form of thinking that takes in more factors and has these Wigmore charts, what's the danger that you're going to end up with a decision-making process that's so complex
well, absolutely
impractical
right.
to use? I mean, after all, I mean, I sat on a murder trial. It was 2 weeks long. You know, if cost God knows how much. If you Any comments on that?
Well, something that I'm when we were talking about setting this project up, we were in touch with somebody who was very senior at NICE, who was involved in a lot of decision making about just the kind of examples that we're talking about. Your sort of typical, relatively expensive drugs that people take for long periods of time, for, chronic disease things. And the comment there was that there was this enormous layer of thinking that's already happening in these decision-making processes that kind of already looks like this. So it's not that we're saying that you should introduce a whole new way, a whole new way of thinking about it. Actually, as you say, thinking about and interpreting the results of clinical trials is fantastically complicated already. And actually, I think one of the reasons it is complicated is because this kind of work happens, A. But B, there's no sort of tool. There's no method, there's no scheme, there's no grade guide. I mean, grade is 400 and something pages long, right? It's terribly complicated anyway. But there isn't even the most basic kind of guidance for how to do that. So it happens. It happens very informally. And I think, from what I've heard, and I haven't been party to these kind of conversations really, but that it happens in an extremely inconsistent way. So this is more about making explicit something, I think, that's kind of secret is too strong, but secret. Does that make sense? And I entirely take the worry that all that anyone does whenever they try and improve the way that you work with evidence is just make everything more complicated. I mean, that's something that we're wary of. But I don't know how to promise that we won't make it worse. Promise,
Well, that's a neat thing about diagrams, that they can actually simplify. So you're introducing a new thing, but if that diagrammatic thing helps to articulate it,
Mm.
it can be
I hope so.
simplified.
Mind you, given all of the if you read the lawyers' manuals about how to construct Wigmore charts, they really make it sound very, very hard work to go and do this. So one of the things that we have coming up is some actual time spent trying to draw just these kind of charts for some real examples. So hopefully, I mean, if I end up disappearing into that forever and ever, I'll know that this isn't a viable way of working.
I was wondering if one potentially useful application would be situations where you quite frequently have misdiagnosis. So long periods where something isn't spotted. I actually work as a lawyer in this area a little bit. I'm quite new to it really, but some people in our chambers do quite a lot of clinical negligence.
Okay.
And you do get a lot of, I guess, misdiagnosis cases.
So this is where where a clinician should have identified something that's relatively common. That sort of misdiagnosis.
Yeah, precisely.
Okay.
So a case recently was quite an obvious example. This lady had a hip replacement, and it was a strange thing because she had some, really quite capable consultants looking at it, orthopedic consultants looking at it for a long period of time, and they looked at a lot of obvious things. So was the implant aligned properly? Took some blood tests, made sure there wasn't an infection in the joint, etc. And eventually it was just the fact that the adductor muscles at the time of the operation hadn't actually reattached after the operation, which apparently can just happen without anyone doing anything wrong. And that seems like quite a simple example of a situation where there's lots of people scratching their head and saying, what's missing here?
Yeah.
I was just wondering if you could use the same methodology to map out essentially kind of charts that would help people.
Yeah, I mean, I think that example might be quite a good one. I mean, it was one of the ways that we're thinking about doing this is actually to try and do some of the translation work by starting with medical legal cases. Okay, I mean, obvious differences between the kind of clinical decisions that you want, but at least so. I mean, the thing that would interest me there enormously is trying to find kind of nice mechanistic support for some of the kind of, I suppose, what you would be otherwise sort of generalizations, right? In that kind of case, one of the other sort of interesting examples was cases where mechanisms are in dispute for one reason or another. There was a suggestion that we worked on shaken baby syndrome, which is probably too complicated and too controversial. There were, I mean, various other kind of suggestions, but I mean, I think it would be interesting to see what that kind of case is, because then at least you would be able to kind of model the kind of link between inferential reasoning steps and this kind of more causal, more traditional philosopher interest side of the story, I think.
Do you feel that the use of these mechanisms and charts and things has any potential to be sort of used with actual patients? Because to me it seems that, for example, some patients might want to sort of be involved in the process, and sort of using these charts and stuff might actually help the clinician to make decisions. So taking into account the sort of subjective things like what they want, their needs and their wants, sort of could be used. The charts could be used to help with that, like if the patient is also involved in it.
Yeah, I mean, I think that's really interesting. And one of the things that I like is that you can change the level of detail that you put into these kind of charts very freely. And so I mean, the kind of example where you might have two cases, you're trying to pick between two treatments with somebody, and price isn't an issue, right? There's no need to have a great big wad of kind of health economics kind of reasoning. So I mean, I can see ways that you can adapt these for different circumstances. Whether anyone actually wants to try and enumerate all their preferences at a time when things are difficult, I've got no idea. I mean, it's sort of, it might already be quite close to the kind of conversations that people have about competing therapies. I had this strange conversation with a hairdresser last week, who is, as most hairdressers do when they're getting towards their 50s, have to start having very serious things done to their thumbs and shoulders because everything gets broken by standing like this and working for 8 hours a day. And they have these very difficult decisions to make about whether you have conservative management, so you have steroid injections into your tendons, or whether you do something a bit more surgical looking. Because there's this very complicated decision for them that involves all the sort of usual stuff around your preferences about what kind of medical care you'd like, but then very direct economic kind of consequences and a very detailed risk-benefit analysis. So it turns out that you get fewer side effects apparently long-term with the surgical case, but they tend to be very much more serious, and they tend to stop people working. And actually those kind of decisions are very hard to make informally because you've got dozens and dozens and dozens of factors that are very uncertain, that are uncertain and all the rest of it. So I could see cases like that where you might want to try and reason some of this stuff out in that way. And it's not just a decision that's entirely about your preferences, right? You will have relevant evidence from clinical trials or from kind of reasoning about how diseases work and so on and so on that would support and be useful, in fact vital, to that kind of process, right? You can't just do it all by preference. So maybe, but not all the time.
Personally, I like visuals. I mean, as a patient, might find this an easy way of understanding what the factors are. Depends on the patient.
I think the case where different treatments have very different side effects is a really hard problem for the way that doctors get taught to communicate, and just for communication in general. It's very hard to explain, I think. And this might be one way that you might try and maybe, if not simplify, at least make it more complicated in an interesting and informative way.
In terms of the first day, is it seen as almost a way of being able to replace the heuristic element of clinical decision making? And if so, is that necessarily good for the business sense that really what you're saying is trying to understand the complexity and all the factors involved, but kind of actually understanding that that's not possible to get all through? And is it necessarily heuristic the way we make our decisions, that it's not just gut instinct doesn't necessarily mean it's not based in fact, but actually that the kind of decision making process is so complex and actually psychologically we that in a way that you cannot make explicit, and that it should be a factor in sort of informs your heuristic decisions rather than there being an algorithm or a body who can then remove that element of your clinical judgment.
Thank you for the question. I promised that I wouldn't use the word heuristic to myself because it's a word I use too much, and I think this is a really nice example of why heuristics aren't just kind of, just whatever you like. So, I suppose, do people who propose the kind of ideas that we call EBM want to do away with clinical judgment? No, I think not. I think that, though, the people who apply EBM to things quite often have it in mind. I mean, one of the really interesting things that I've been reading up on lately is the kind of role in very standardised clinical guidelines as a shield against litigation, right? And hospital trusts love clinical guidelines, just love them, because that's the recipe, isn't it?
It's a tool, but actually for trust.
It's a tool for the trust. It has nothing to do with. So I mean, there is that very cynical story there about this pressure, about about this kind of idea that knowing about these 2 or 3 trials replaces all the usual rather complicated judgment that you would work with on a patient about a decision, and it would all get boiled down to, well, the trial says this, and I think that might be true, but I don't think it has very much to do with the people who proposed and developed EBM as a kind of epistemological solution to a problem about decision making. I think this has much more to do with, well, the kind of environment the clinicians work in, right? It's standard, it's predictable, it's cost effective.
If you have something that is standard, it does allow you to be predictable, it does allow you to be cost effective because it means you know which drug you're buying.
Yeah, it does. But I think the litigation shield thing is there too. You can't get sued if you've done what you're supposed to.
Anything else? Okay, well, so much so far tonight. So thank you all for coming.
Oh yeah, hang on. Okay, there we go. There we
We
go.
have the next program will be 2 weeks from today, same time, same place, right here. We have Aneta Rid from the Department of Social Science, Health and Medicine, talking about the social value requirement for clinical research. That to do research, it has to have social value, and she's going to defend that. So I